Hello, and welcome to the DESERA Clinical Education Oncology Podcast. I'm your host, Ryan Topping. Today's episode features Dr. Aditya Bardia from the Geffen School of Medicine at the University of California in Los Angeles, California, and Dr. Ruta Rao from the Rush University Medical Center in Chicago, Illinois, as they discuss antibody-drug conjugates for HER2-negative, ultra-low, and low metastatic breast cancer, including contemporary HER2 expression classifications, optimal use of ADCs, and best practices in patient communication. This episode is part of a larger educational program titled Integrating ADCs into Patient-Centered Management of HER2-Negative, Ultra-Low, and Low Metastatic Breast Cancer, Enhancing the Patient-Provider Therapeutic Connection. For more information, along with a link to the larger educational program, please visit the show notes for this episode. Now, let's get started and hear what our experts have to say about this important topic.
Hello, everyone. I'm Aditya Bardia, medical oncologist at UCLA, and look forward to the discussion today.
And I'm Ruta Rao, a breast medical oncologist at Rush University Medical Center in Chicago, and I'm pleased to be here with you all today.
Excellent. Thanks, Dr. Rao. Let me set the stage. Why don't we talk about HER2 low, HER2 ultra low, and what does HER2 expression essentially mean in metastatic breast cancer in 2026?
Yeah, it's a great question, and I think this is a definition that has really evolved over the last few years. Previously, we used to think of HER2 classification in a very binary way. It was either HER2 positive or a patient was HER2 negative. But today, we have these classifications of HER2 ultra low and HER2 low. I apologize. My phone went off, but I had put it on Do Not Disturb. Let me say that again. But today we have newer classifications. We know that our patients who were traditionally thought to be HER2 negative can be reclassified as HER2 low, HER2 ultra low, or HER2 null, which is truly zero. And this is really important for us to know about a patient's tumor because it can make them eligible for treatments, specifically for trastuzumab deruxtecan, which is now approved in the setting of HER2 low and HER2 ultra low ER-positive metastatic breast cancer.
Yeah, absolutely. It's been a game changer because previously we were looking at HER2 positive and negative for trastuzumab, but HER2 negative does not necessarily mean that there is no expression of HER2. So if we go back and look at our classification for HER2, HER2 positive was defined as immunohistochemistry 3+ or 2+, along with FISH amplification. But 1+, which means that there is HER2 expression, was classified as HER2 negative, but now we have this new category of HER2 low. And even HER2 zero technically was tumor cells that have either no expression or 0 to 10% of tumor cells having some HER2 expression was classified as HER2 IHC 0, but 0 is not necessarily 0%, and that's this new classification of HER2 ultra low, where 1 to 10% of tumor cells have some HER2 expression. So it's really been a game changer. Dr. Rao, have you had pushback from oncologists or pathologists in terms of if there's a tumor that's, say, HER2 IHC 0 or HER2 IHC 1+, trying to reclassify that as ultra low or HER2 low?
You know, we really, in clinical practice, have not had that pushback. We did have to make an effort to discuss and educate our pathologists about trying to define, especially the category of HER2 ultra low. The patients who are 0 but have this, as you mentioned, 1 to less than 10% expression of HER2, because otherwise these were patients who were classified as HER2 0. And so to ask them to go back, or now in our pathology specimens that they report out now, we're asking them to report 0 or 0+. And once we kind of had this discussion with them, it was pretty straightforward, but I think it was a matter of educating them. They're always trying to help us out in terms of finding new treatments for patients. So they were more than willing to do it, but it was just letting them know why it makes a difference to us clinically.
That's a great point. And that's, education. so that the team is aware that this is a new category and it's important because that's actionable. So that's a message for practitioners, providers, oncologists, that if there's a patient who has HER2-negative disease, or you see a prior specimen that's HER2-IHC 0, 0 does not mean 0%, and it's important to evaluate and see if that could be ultra low, because that's potentially actionable with newer therapies, particularly trastuzumab deruxtecan. Any final thoughts related to this topic, Dr. Rao, before we move on?
Yeah, I think, one other thing I think about when I'm seeing these patients with metastatic breast cancer is that we do have some heterogeneity in their different tumor samples. So oftentimes you might have a patient who had a biopsy that has some HER2 defined on it, a mastectomy or lumpectomy specimen, and then a specimen from their metastatic disease diagnosis. So I would like to identify any patient who's eligible for this. So in my practice, I'll look at any of these specimens to see if there's any HER2 low or HER2 ultra low expression in any of them, and then consider the patient eligible.
Great point. Great point.
Great. So let's move on, Dr. Bardia, and I'd love to get your thoughts about antibody drug conjugates. We've seen these really take over in terms of treatment of our metastatic breast cancer patients. So maybe we can start by talking about antibody drug conjugates in the ER positive metastatic breast cancer space.
Absolutely. These are slowly replacing chemotherapy. So if you look at management of ER-positive metastatic breast cancer, usually we use endocrine-based therapy, CDK4/6 inhibitors, oral SERDs if the patient has ESR1 mutant disease, PI3 kinase AKT inhibitors for patients who have alterations in the PI3 kinase pathway in the tumor. But then after a patient has disease progression on endocrine-based therapy, we usually go to chemotherapy, and that's where antibody drug conjugates come in. The current ADCs we have are essentially targeted chemotherapy. They have an antibody that binds to an antigen that's overexpressed in tumor and then deliver the payload, which is a chemotherapy agent. There are three that are FDA approved at this time: trastuzumab deruxtecan, sacituzumab govitecan, and datopotamab deruxtecan. In terms of these different agents, it's important to know about HER2 low and ultra low because that's actionable with trastuzumab deruxtecan. Pivotal studies, Destiny Breast 04 and Destiny Breast 06, essentially showed that trastuzumab deruxtecan or TDXT is superior to standard chemotherapy, be it eribulin, navalbine, or even oral capecitabine. The progression-free survival was much higher with TDXT as opposed to these standard chemo agents. So essentially that has replaced standard chemotherapy. And in these trials, patients with HER2 low and ultra low disease were included. And that's why it's important to look at this. And in these trials, any prior specimen that had HER2 low or ultra low was considered eligible for the trial. So it need not be the last biopsy. It could be the primary breast cancer specimen or a prior archival specimen. The other agents target TROP2, so both sacituzumab govitecan and datopotamab deruxtecan target TROP2. So the HER2 expression in a way does not matter because the drug targets TROP2. So these are drugs that are approved both for HER2 low, ultra low disease, as well as the small category of HER2 IHC null or completely zero. In terms of how to use these agents, I think these are all options to consider. Generally, given the significant results we've seen with TDXT and significant magnitude of overall survival improvement, generally TDXT is prioritized first. And then after that, one has an option of using Dato-DXT or SG. But I'm curious to hear from you as well, Dr. Rao, given that we have these three agents, how do you use them? How do you sequence these drugs for patients with ER-positive metastatic breast cancer?
Yeah, I think, having them available has really been, like you said, a game changer for our patients with metastatic breast cancer. And the issue we face in clinic is that we don't really have any data on how to sequence them. I would agree with what you said that in general, if a patient has HER2 ultra low or HER2 low expression, then trastuzumab deruxtecan is my first choice of ADC. If a patient is truly HER2 null, then I think we really have our choice between Dato-DXd and SG. Um, in subsequent lines of therapy, I think what we've seen from some real-world analyses is that sometimes there is some efficacy with a second ADC after a first one, but in general, we kind of get the biggest bang from our buck from the first ADC that a patient receives.
Yeah, makes sense. And partly speaks to potential cross resistance between these drugs because all the three FDA-approved ADCs in this space, Dato-DXd, SG, and TDXT, have similar payloads. It's identical with Dato-DXd and TDXT, which is deruxtecan, and even sacituzumab govitecan. The govitecan and deruxtecan both are TOP1 inhibitors, so there's definitely some cross resistance because of similar payloads, and it's an open question at this time in terms of how to sequence these drugs.
Right. And I think one of the things is when a patient progresses on one, we're not quite sure if they've become resistant to the antibody or
Mhm.
to the target. And so we know that trastuzumab, deruxtecan, and Dato-DXd have the same payload, and Dato-DXd and SG have the same antibody, the anti-TROP2. So I think that's yet another thing to think about when we're sequencing these.
That's a great point. Absolutely. And I think we need more research in terms of trying to understand resistance related to these ADCs and how to sequence them. I guess at this time, then the question becomes how do we select, say, a patient receives TDXD and then has disease progression? How do we select between SG and Dato-DXD? And I can talk about my practice. Often it boils down to the adverse effect profile. These drugs have different AEs. So both SG and Dato-DXT are TROP2 ADCs with similar payloads, but the side effect profile is quite different. SG or sacituzumab govitecan, the three most common AEs are neutropenia, including grade 3, grade 4 neutropenia rate of more than 50%. So 1 in 2 patients will have an ANC that's significant that would need some intervention. The second is diarrhea, and the third is alopecia. And nausea vomiting is also seen, but often can be managed with 3-drug antiemetic regimen. In contrast, with Dato-DXd, it's mucositis. That's the number one side effect. Usually you need steroid mouthwash for primary as well as secondary prophylaxis. Can also cause keratitis. And very rarely, 1% or less can cause significant pneumonitis as well. The schedule is also different. Sacituzumab govitecan is day 1, day 8, every 21 days, and Dato-DXd is every 3 weeks. So if I have to choose between SG and Dato-DXd, given that efficacy looks similar, it's often the schedule as well as side effect profile that helps me discuss this with the patient and then select one option. How about your practice, Dr. Rao?
I would agree with you 100%. I think, one of the things to think about with Dato-DXd, like you mentioned, it's really nice to have something that patients are only coming in once every 3 weeks for. But to prevent the stomatitis, we do recommend using a steroid mouthwash 4 times a day. And sometimes that can be really burdensome for patients. And if they develop stomatitis, we know that that can be a severe side effect. Similarly, there's the ophthalmic side effects with Dato-DXd, for which it's recommended to use eye drops multiple times a day. And again, we have to make sure we have patients who will comply with these preventative measures so that they don't get severe side effects from this. Dr. Bardia, can you talk to us about using these antibody drug conjugates in first-line triple-negative breast cancer? I think we've seen some recent data presentations in these settings.
Yeah, absolutely. So sacituzumab govitecan, based on the ASCENT study, previously was approved for second line and beyond metastatic TNBC, but ASCENT 03 and 04 evaluated SG with without immunotherapy in the first line setting. And then Tropion Breast 02 evaluated Dato-DXd in the first line setting for patients with metastatic TNBC. And all of these trials were positive and essentially have moved these TROP2 ADCs in the first line setting, SG with without immunotherapy for patients with metastatic TNBC, and then Dato-DXd as first line for patients with metastatic TNBC as well. And the question is how to choose between SG versus Dato-DXd. And as we were saying, for ER-positive disease, it's similar based on side effects as well as the schedule, day 1, day 8 with SG versus every 3 weeks with Dato-DXd. Continuing on this theme in terms of patient counseling, Dr. Rao, the team did a survey where they asked in terms of, unmet need and what patients and patient advocates would like to hear about. And a common theme was how do we as oncologists, as providers, discuss treatment options with patients, and how do we counsel them on side effects? So what's your opinion in terms of, or your own clinical practice in terms of discussing side effects with patients and counseling patients?
So I think it's really important to be upfront with them because, sorry, I think it's really important to be upfront with them about the side effects that they may experience. I try to go through it with the patients, but I think this is also a team effort. So I involve my clinical pharmacist, as well as our nurses, to talk to the patients about the side effects that they can expect, what supportive care measures to use, what preventative measures to use. I think it's the more education that we can give them, and the more that we can encourage them to be in contact with us when these side effects develop, so that the side effects don't get very severe, and we can step in and help them with management of the side effects. I think it's really just important to provide that education before they start the treatment.
And that's a great point. And often, if you spend a lot of time in the first visit, it saves time during subsequent visits, and it's also, a good clinical practice to let patients know about potential AEs and potential mitigation strategies. So, for example, we were talking about neutropenia. When we talk about neutropenia, mentioning that there is a medication, GCSF, belfilgrastim or filgrastim, one could use. Similarly, when we talk about diarrhea, mentioning that there's loperamide one can use. Talk about mucositis, talking about steroid mouthwash. So just whenever we're talking about AEs, also talking about the potential mitigating strategy is in general quite helpful. And the other point to make is that this is not just one time. The key is follow-up. And often when you start a new medication, it's good to have a date follow-up just to check in. And that could be with the nurse practitioner or the pharmacist, someone from the healthcare team. So just check in how the patient is doing. It could be a virtual visit as well. It could be a phone call. But just, when you start a new medication, having a short-term follow-up often can then help on maintaining compliance and adherence to these therapies. Because if you're able to manage the AEs, often patients would remain on the drug. But if they have significant AEs, that's where you have to discontinue, and compliance could be an issue. Your thoughts, Dr. Rao, in terms of compliance and adherence with these drugs?
I think you're absolutely right. I think, the main way we can get our patients to continue to be compliant and take these drugs again every 3 weeks or 2 weeks on, 1 week off, is to help them manage and mitigate the side effects, just like you mentioned.
Fantastic. Fantastic. Well, this was a great discussion. We talked about the new HER2 classification. We talked about newer therapies, ADCs. We talked about their side effects, how to select different ADCs, and how to counsel patients and help with adherence. I really enjoyed the discussion, Dr. Rao. Thanks for joining.
Yes. Thank you. Me too. Thank you so much.
Thank you, Dr. Bardia and Dr. Rao, and many thanks to you, our listeners, for joining us. As a reminder, to view the full program integrating ADCs into patient-centered management of HER2-negative, ultra-low, and low metastatic breast cancer, enhancing the patient-provider therapeutic connection, please click the link in the show notes. And be sure to check back regularly for more episodes on important DCERA clinical education oncology podcast topics.